first of all, before I get started, I just want to thank Dr. Weber and the patients in the focus groups that recommended my name to speak to you all today. This is the first time I'm going to be presenting this material in the face of survivors, and you really are the reason why I speak about what I speak about, and it's through my work at Sloan Kettering that I've gotten quite passionate about meeting the needs of your particular population, specifically as it relates to you all facing GI cancers. So I wanted to just sort of put that in perspective and before I get started. So the content for my discussion today is really to focus on defining who the young adult is in the world in general. What are priorities typical for this young adult person in the world? And who is the young adult facing cancer? I'm also going to define for you the young adult in the context of their family of origin, and then I'll go through some normative developmental patterns for this age group. And then I'm going to take a look at the young adult couple more closely and just sort of highlight some unique complexities within that sort of relationship, particularly when you're facing a cancer diagnosis. And then I'm going to give some broad general overviews of just cancer in the family in general and the literature that's out there that sort of acknowledges cancer as a family illness, and I think something that healthcare in general should be taking into consideration more closely. That's my family therapist in me speaking. And then some important considerations when treating the young adult patients like all of you were talking about today. Just the important things to recognize that are unique and distinct, which I think will enhance sort of your relationships with them as they move through the treatment experience. And then I'm going to talk a little bit about resources that are available and things to consider in your particular institutions going forward that you might want to think about implementing. So who is the young adult? Young adulthood, back in the day, Erickson sort of identified people between 18 years of age and 35 as young adults. Developmental priorities typical at this stage, which you all have captured. Number one, they're working to establish autonomy from their parents. So they're sort of in that beginning stage of developing their own identity and their own sense of maturity outside of their family of origin. They're developing a personal set of values and identity that may be different from their family of origin, but some similarities. They're looking to find strong peer relationships, including intimate and sexual relationships. And they're also looking at their professional identity. What are they wanting to do in the workforce, and how are they really going to sort of conquer that? So who is the young adult facing cancer? I don't think there's a better way to talk about that without survivors speaking, and so this is a piece of an article from a New York Times young adult person who was treated at Sloan Kettering, and I found her words to be very powerful. Where cancer is concerned, it's safe to say there's no such thing as good timing, but having a life-threatening disease in your 20s carries a special set of psychological and social challenges. It defies our very definition of what ought to be. Youth and health are supposed to be synonymous. If only I could sue my body for breach of contract with the natural order of things. Cancer magnifies the in-betweenness of young adulthood. You're not a child anymore, yet you're not fully ready to live in the adult world either. After my diagnosis, I moved back into my childhood bedroom, and as I get sicker, I increasingly rely on my parents to take care of me. But at the same time, I've had no choice but to grow up fast. Daunting questions that most of my peers won't have to consider for many more years to come have become my urgent everyday concerns. How will I hold on to health insurance if I'm unable to work? Will I be able to have children? How long will I live? So, in the young adult oncology community, there's been a huge amount of research and literature that sort of speaks to the young adult cancer experience and why it's so distinct and separate from the pediatric world versus adult and geriatric oncology. And there's a huge amount of organizational interest to better serve this population, particularly when young adults are going through the treatment experience and the post-treatment reality. In my particular work at Sloan Kettering, I worked on an inpatient floor where people facing gastrointestinal cancers would come in and get admitted with complicated medical and pain management needs, often in sort of that beginning of the physical body decline, and they still had goals to get to the next treatment, but they were sort of physically experiencing the signs that they would more likely transition towards end of life. And in my 7 years on that floor, I saw a lot of people in their 20s and 30s, and that's when sort of my passion for just kind of thinking outside the box, like how is everyone, looking at the young adult patient, and are they speaking to them in ways that highlight quality of life in the midst of this, while they're continuing to have goals to live through their cancer reality. And so it became a goal of mine to take a look at what literature was out there to sort of not only meet the survivors' needs, but also those facing end of life. So who is the young adult within their family? So we know that, again, going back to the literature, some of these young adults in their 20s and 30s may, be dating, some may be single. So I think it's important to separate the two when you're thinking about working with them during a treatment experience. So the single young adult, questions to consider: are they living on their own? Do they live with roommates? Are they interested in dating or having children in the future, even if they're not currently in a relationship? And then I think also what's important, which sometimes gets unnoticed, is how do they define their relationship with their parents? Some of these young adults may have a close relationship with their parents and may want their parents to be primary caregivers. Others may not, and they may identify a good friend, or they may, identify someone in a church community. So never making assumptions that who is in that young adult's family and who their important networks are, I think is really important. And asking them, who do they identify as a primary caregiver? Then you have the young adult in a relationship, and again, I think this is very unique and important to sort of not make assumptions. Some of these relationships may be brand new, so they may be dating someone only a few weeks in or a year in, and some of them may be married, engaged, and so where they are in that trajectory, I think speaks volumes to, again, asking them where do they see that partner fit in the treatment experience, and where do they want them to fit, and supporting their decision through that process. Also, I think it's connected in both sides, single and the young adult in relationships, fertility considerations, and just really important to, which all of you were talking about already, make it known that you sort of honor and support their wishes to either have children if they don't, and help them work towards supporting that as best you can. And again, like the role of parents as caregivers. So within the family system structure, if you go back and these folks are adults in the world, but they're not fully, totally grounded in where they want to be and who they want to be. And so it's natural for them to regress back to kind of looking at their parents for support, that's a normative reality. And at the same time, sometimes that the parents kind of weigh in a lot more in treatment decisions than we would like to see, and even the patients would like to see. So I'm going to talk more about that in a little bit. But then where do their siblings fit? I think this piece of family gets lost in the shuffle a lot. People that have brothers and sisters, and kind of who's talking to them, and who even knows what supports are available for them when you're facing cancer. So I've done a lot of work at Sloan to really bring awareness to the unique needs of the young adult couple, and I think this is an interesting slide, because what I've found is that when we look at, so you've got the young adult patient living through a cancer experience, and some of the individual challenges we know that are out there, they feel quite isolated. They feel like they can't relate to their peers, because their peers are continuing to do things like go to happy hours and have fun in the dating world, or really build up their careers, and they may not be able to do that when they're in the midst of treatment. There's an interruption in that developmental milestone reality, and again, like I said, that individuation from parents is also a goal. And the solidifying of peer relationships is important to them, and the values and identity. And for the couple, when we think about the young adult relationship, they too are developing, they are feeling isolated from their peer couples as well, because their couples are continuing to advance and maybe get married, maybe have families, and that's sort of on hold for people in the midst of treatment. And those developmental milestones are also there as well. And that autonomy piece about parents, these young adult patients have to rely on their parents if they choose to, a lot more than the healthy young adult couple, and so that gets in the way as well. So I just think, again, for the couple and the patient, you're having a shared experience, and so it's just important to recognize that. So the literature out there that talks about cancer as a family illness, John Rowland is one of, I hope you all know, he's based out of Chicago, and he has a book on family and illness, but one of his quotes that I think is good: illness, disability, and death are universal experiences in families. Healthcare providers need an organized way of thinking about the complexity of cancer in a family unit, and that cancer is a family illness. King and Quill in 2006 reference, many medical staff view working with families as one of the most difficult aspects of palliative care. They argue that family concerns should be understood and addressed. And Dr. Zader and Kassane from Sloan Kettering actually did some research that discusses the importance of management and assessment of distress in families at the end of life, and how family relationships can often predict individual distress at the end of life. So again, very powerful thing to think about, how family interactions and family relationships might be impacting care. And sometimes we don't even think about that. So just to give you an idea of the way that I work as a clinician, which I think is interesting, particularly in oncology, and my hope that people start looking at the family more. So in the family therapy world, when we're looking at treating, we're looking at, again, we're attending to the form or the structure of the interactions in the family. We're sort of mapping the family as they present themselves and how they're relating to one another. And we're thinking systemically, so we're always noting that individual challenges always occur in context. And we're looking at communications between family members in the here and now. So if you see people in clinic visits and you're noticing as you're relaying information that different family members have different responses, just paying attention to people's reactions when they speak can be a lot of information about how that family is relating and connecting to one another. And you're paying attention to circular interactions, so that, just like I said earlier, behavior is both a response and a stimulus that forms this particular family's rules. So as it pertains to treatment goals and decisions, if you're introducing different options available, again, honoring the patient's voice, but seeing what might be getting in the way based on how family members are responding in the moment, I think is pretty huge. So systemic interventions to consider if you start to look more at treating the young adult patient and their family as a whole, valuing and exploring multiple perspectives. So family members think differently about their current situation. They're all living the same shared experience of illness, but they have different reactions and feelings based on their own anxieties and worries about what that person is living through. Now, no perspective is inherently better than the other. It's important to sort of hear and acknowledge and understand how everyone's reactions in the family might be impacting that particular patient's decisions. And you want to balance the both and. So you want to help the family hold these different ways of thinking and supporting that and knowing that that's okay, that shouldn't be perceived as a conflict. And finding balancing, to hold this both and, I think, is critical, particularly when illness is getting a little more compromised and complicated as it relates to treatment decisions. And you want to understand your particular family's narratives that you're working with, the current and the possibility for new. So when we think about engaging the young adult and their family in particular, what I think is important to consider, and this is probably geared more towards oncologists providing the treatment, but who is present during these clinic visits? If multiple friends and family are present, how do you sort of walk in and focus on the young adult patient specifically? And I think it's really important to ask that particular young adult if it's okay to talk to everyone who's present, or if they'd prefer to meet with you individually. And then if multiple family members or friends have questions they want to ask you, how do you sort of support those questions and at the same time see how that particular patient is responding, and always making sure you hear the patient's voice in the midst of that. And again, like, I really think noticing these communication patterns between family members, I can't tell you how many referrals I've gotten at the hospital, high conflict family, or this family isn't getting along. And, you know, at the end of the day, when you sort of hold what's underneath that, everyone's just managing their own anxiety and worry about what's best for this patient. And, you know, I think we as practitioners have a role in supporting that, and at the same time making sure that that young adult's decision doesn't get blocked by maybe like the identified family members that are sort of interfering with care. And so that, on that note, I think it's really important that in addition to young adults walking in with a whole lot of support, that you allow time to be alone with your young adult patients, and you really spend time getting to know what their quality of life goals are, gauging what they may want to share with you that they can't share with other family members present. Oftentimes the fear and the anxiety are pieces that they may want to have explore with you before they explore with their family. And like we've been talking about all day, important considerations unique to this population. I think body image is huge. I can't tell you how many sessions I've had with young adults where they talk about, you know, it's funny in colorectal world, like if you go through these aggressive measures and you're having surgeries and you're getting the ostomy, oftentimes doctors are saying, but this is a curable way to sort of treat, and you should be so happy. And at the same time, they can't even look in the mirror, you know, at what they're facing, and it takes a while for them to adjust to that. So I think the delicacy in how you're introducing these treatment options and really being clear about the risks and the benefits prior to is really important, and doing counseling around that. Sexual functioning also, you know, young adults are very healthy, male and females, and in the midst of sort of stage 4 cancer, they could really feel alive and healthy, and so their want for sexual activity and intimacy continues to be very real. And so I think knowing what side effects are typical to treatments and also versus just their libido is key. And so I know at Sloan we have clinics available that talk about the sexual functioning that patients can go to. I don't know if that exists everywhere, but I would highly recommend you look into those types of things. And then the quality of life goals for these patients may be very different than the older adult patient, meaning, you know, in the midst of aggressive treatment, they may want to go on vacation for a week, or they may want to go and have a glass of wine. And so allowing for conversations that might be unique to that age group in the face of the treatment planning is really important, and it makes them feel heard, and it makes them feel like a person as opposed to a patient, and I think it's just really important. So fertility, I'm going to introduce my colleague Joanne in a minute, who I'm very excited for you all to hear, but she's going to go into depth about that. And just the social isolation. Again, I think when you're a young adult in the world and you're facing a life-threatening illness, you're tapping into things that people much older are having to think about, like your own mortality, and that changes you. When you talked about last year, talking about this idea of a new normal, it's a new life perspective, and so even beyond treatment, you may be struggling to sort of connect with your peers and, you know, think you feel very different, and that continues over time. And so how you support your patients and survivors with that, I think, is key. So I think the collaboration too between the oncologist and the mental health provider, if your young adult patients are connected to a counselor, is really important, because sometimes, you know, treatment clinic visits go very quickly, and so the sessions that these folks may have with their social worker or psychologist, they may go into more detail about what their particular challenges are. as it relates to how they're living through. And so communication between that provider and the oncologist can really help, I think, aid in better quality of life planning in the midst of treatment for these patients. And I think it's going to make the patient overall feel more supported and taken care of. And it's going to highlight how interdisciplinary team communication happens, and it's real. So I'm going to end talking about a case example where when I kind of described who the young adult is in their family and the multiple complexities about, here is someone trying to move away from their family of origin in a productive, developmentally appropriate way, and at the same time being faced with a life-threatening illness. Sort of how does that happen and what gets changed and restricted? So Brittany is a 28-year-old female, and she was recently engaged when she was diagnosed with stage 4 colorectal cancer. She lived with her cancer through multiple surgeries, chemo, radiation, for a period over 4 years. Prior to her diagnosis, she was planning this big white wedding, she described, and she was really looking forward to it. And actually, in the beginning of her treatment, which I'll go into, she kept partializing and saying, when treatment is over, I'm going to get to this. When treatment's over, I'm going to get to that. So she kept postponing her big wedding, thinking she was going to feel better and get to have what she dreamed of having. She also wanted children, and she eventually wanted to move out of New York City. It wasn't her native state, and she wanted to return to the South, warm weather, with her husband. She wanted to buy a home, and she wanted to settle into a life together, have a family. She also had goals to continue working, and towards the end of her cancer experience, she ended up just being on 4 different systemic chemo treatments with goals to just keep her cancer contained as long as possible so that she could keep living as long as possible. So what was it like to work with Brittany and her family? In the beginning phase of treatment, like I just mentioned, she was looking at her cancer experience in a box almost, that she could, everything was localized, she could have her surgeries, have her treatments, the cancer would be gone, and she could move on with her life. So the way she was thinking about her life narrative was just like that. This is just a situational experience that I'm going to go through. I'll get back to my world after, I'll get back to my wedding. I don't have to worry. And also, even though she was with her partner for a long time, she was recently engaged, and she didn't yet trust that her husband could be a primary caregiver. So she really looked to her mom as the primary person she wanted involved in the clinic visits, which was a very interesting piece dynamically. So then as she moved towards the middle phase of treatment, meaning that her cancer was continuing to progress, she needed to look at different treatment options. I met her when she was having her ostomy surgery, and she asked to meet with me after that admission, and I'm one of the family therapists in our family therapy clinic, so it all worked out. And the goals of that family therapy were to assist Brittany with balancing her new relationship with her husband and really fostering that, which is a goal, a life cycle goal, right? Exploring ways she could complete certain life goals while receiving cancer treatment at the same time, and starting to trust her husband more, so doing a lot of relational work with them as a couple to see what was getting in the way of her ability to be vulnerable with her husband, and also where was her husband in wanting that sort of role, and how confident did he feel in being that primary caregiver. We also explored her want to have a child, and she did a lot of work with our fertility clinic to preserve embryos. She even, had enough money saved to do a surrogate mother. I believe she had too much radiation to her abdomen. I don't know the specifics, but she had confidently felt that she couldn't carry a child, and so she was going to go that route. And then she, through the different treatment side effects, she realized that she wasn't able to return to work, so her professional life was going to be compromised, and we worked towards that in the therapy for her to be able to grieve that loss, and at the same time see where she could fulfill professional milestones outside of a primary job. At the end phase of the treatment, it was realized that her cancer was continuing to progress, and that despite all of these options, it was continuing to grow. So this is where I think collaboration with myself and her oncologist became very important, because we, even though this couple and family were still in the thick of moving towards cure, we knew, that this was ultimately going to end her life. And so I had to think creatively, what are the milestones that this young adult couple could face or continue to experience, even if they've lost the ability to have children, they've lost the big white wedding. They had a small wedding in Central Park. But so many things that they were grieving over. What were the things that they could still accomplish together? And one of them was her moving to the South and buying a house and having, she wanted to buy a dog and have that maternal experience. And so talking with our oncologist, we encouraged this couple to move earlier than they were thinking. And her oncologist got her hooked up with all the same chemo she was on here in New York, in that particular state, at a cancer center, and we supported that move. And so she was able to live for about a year in that state before she started declining. And in my opinion, this is where, if you spend time to think about the unique ways you can support these patients, which again is different from pediatric and adult, you can have them find some levels of growth in the midst of what they're losing. So I said this already, but despite so much loss, these young adults can continue to make milestones, and I think as individuals and individuals in relationships. The treatment plans should include quality of life goals. It's very important. Supporting their interest to explore having children, despite the challenges associated with that, even if you just spend time to hear them and hear them get emotional about the possibilities that they might lose that, I think makes them feel heard. And seeing the value of interdisciplinary resources, connecting this young adult and her family for counseling was key. And just to make a note, even though she looked at her mother as her primary caregiver, towards the end of therapy before she moved out of state, she had confidently moved towards her husband going to the clinic appointments. Her mom had moved to New York to be that primary caregiver and had since moved back home so that her husband could be that primary caregiver. And I spoke to him on the phone weeks before she died, and he was able to advocate for time alone with her when she was declining, and told me about the special moments they had as a couple and how thankful he was to have worked through that. And so that's things that I walk away in the face of so much that we see that's sad and frustrating about colorectal cancer in young adults specifically. This is a case to me that illustrates hope in the midst of all of that. So knowing your resources, I think for doctors, clinicians, everybody that's sort of working with patients in some capacity, know what support group programs are offered by your particular institutions, in psychiatry and social work, so that you can connect these young adults to the proper resources if it's relevant, especially fertility preservation for both male and female patients. You want to use your social workers. If you think that you need to get this patient a resource, go to your social workers for assistance with this, because that's their role. And know what resources are related to sexual health, and really, talking about that in clinic appointments. So important. So some of the things I've been able to accomplish in my time at Sloan is having young adult couple support groups where young adult couples come together and really talk about the impact of this on their relationship, and really face each other and talk about those challenges. Young adult patient groups and caregiver groups we see everywhere, but young adult partners bereavement groups, I think, again, in witnessing what I've witnessed, where do these young adult widows fit? And so I started some partners bereavement groups specifically for people in their 20s and 30s to come together and talk about that transition. So my hope is that in other institutions, those things can be looked at as well, and I'm happy to be a resource to anybody that may want to chat. So now I'm very excited to introduce Joanne Kelvin, who is my colleague and amazing as it relates to fertility preservation in young adults. Thank you.